Good morning, everyone. It's an absolute pleasure to be here and to see all of you. My name is Lolem Ngong, and I'm with Amref Health Africa. So first of all, let me thank Trudy and the entire team from the Global Health Network. It's been a fantastic journey prepping for our first session this morning. And I'm particularly pleased to chair this panel with really brilliant scientists and researchers from across the world. And they'll talk to us about their work and their contributions to fostering leadership and building lasting, capable research teams. And the way our panel will work is that we'll start off with a plenary talk, if I can call it that. And that will be from Dr. Vasee Moorthy, and he will speak on the needs-driven research in underrepresented populations, which I think is quite important and very critical at this time, particularly coming out of a pandemic. And then following his talk, we'll hear from 4 speakers. Unfortunately, one of our speakers couldn't make it, and that's Miracle Adesina, but we'll still hear from 4 speakers just right after Dr. Vasee's talk. So I want to adhere to time. Trudy was very clear about that. And so without further ado, I'll welcome Dr. Vasee. Dr. Vasee is from WHO. He's an infectious disease physician and immunologist. Welcome, Dr. Vasee.
Thank you so much, Lola, and thank you to Trudy and the team for inviting us. We're here from WHO, from the Research for Health Department, to show our full support for this conference. And I can't think of a conference that I've been happier to attend. I spent yesterday going to the symposia, practical, needs-based research, with clear outcomes for populations around the world. So, in this talk, I'm just going to go through some recent developments at WHO, which is not telling anybody what to do, but it's sharing some framing, which we think is really directly relevant to the conference. This is one slide that shows the many, many global initiatives that have been set up. And if you go back to the beginning of the MDG era, this was in a way the golden period for setting up some of the very important global initiatives, the global funds, the Gavi, UNITAID, many others. And I think everybody would agree these have had a major positive contribution for health around the world. We have seen childhood mortality, for example, as one of the indicators, drop from about 13 million a year to less than 6 million a year. So just in that indicator alone, many millions of children, and a big contribution from this type of big global initiative. But what we've seen more recently in the SDG era is a leveling off of the development assistance for health. And I think a general understanding that we still need these big global initiatives, but we also need to support needs-driven research based on an understanding of what the beneficiaries in communities, in countries around the world need. And that really is much of the focus of the rest of my talk. There are a couple of initiatives over the last few years within the WHO framework that have sought to understand what people like you doing the important work in the field say about the way that the global system has been functioning, what has been working, what has not been working. There was something called the Global Action Plan within the SDG framework, which was bringing together all of these big multilateral initiatives and seeing how they can better work together to deliver impact on the ground. And as part of the research accelerator of this framework, we had a meeting in Rwanda where we invited many of the leading figures within ministries of health in low and middle income country settings. And we asked them how it had been working for them. And they said that still the situation for them is that they tended to find that the global agenda setting dominated over national research agendas, even though there are national research agendas that have been set in most places around the world, that there's poor alignment between the way that the international donor funds are programmed related to national health priorities. There are gaps between the knowledge generation and policy uptake, and access to innovations and scaling of innovations is not really adequately embedded into the pathways. In the more recent clinical trials resolution from May of this year, we have had a recent public consultation where we received many inputs from stakeholders related to the clinical trials work. And one of the streams that we heard from them was that there, as everybody knows, is a major gap still in LMIC capacity support. There is some promising developments in moving towards truly equitable partnerships, but we need to further support these, and we need a greater focus on needs-driven research, which is explicitly supported in the resolution. We need greater collaboration and coordination to align initiatives, and we need to think beyond in the drug and vaccine development sphere, simply licensure to ultimately impact, including affordability, availability, and suitability for populations. Some of the work has already raised some proposals for, how can we move to more country-led forums to translate evidence-based innovations that you have all identified to scale? How can we more drive decision-making to countries and regions? And we've seen beneficial examples of co-funding with grand challenges, for example, and we would like at WHO to see this go much further. How can we again look at better horizontal scaling, by which I mean there are many projects that have taken innovations identified through to scale up at the pilot or the district level, but we don't have a good system to then further scale those to really achieve impact at very large scale. And equitable access. Everybody saw the failure that happened with pandemic, with equitable access to COVID-19 vaccines. We still live in a situation where essentially access to new innovations like vaccines is more based on your financial ability to access those interventions rather than the need. And we clearly need to move beyond that. This is a graphic from one of our living guidelines at WHO, where what I wanted to highlight here is that we only have a few areas where we tend to have strong recommendations either for or against. And this means that in those areas, we have a high quality of evidence. And if you look at the research that underlies these areas, it was generally from just a few large adaptive platform trials. And there, by contrast, there were 18,000 roughly COVID-19 clinical trials, 18,000, which massively displaced trials for other areas. And what we have seen is that most of these were useless. And I say that in maybe what sounds like a provocative way, but it's a fact. Most of them were useless. So we need to really work on this. This is a publication from the FDA where they reported that 95% of randomization arms in these many, many thousands of trials were designed to fail. Even before they completed, it was clear that they, from their design, they were not going to lead to useful information. So we clearly need to work on not only more trials, but higher quality. There are a number of areas that I think have come out of previous work that point to some big themes that people agree that we need to work on to better link the resources to ultimately impact. And one of them is prioritization. And I think that goes back to the title of my talk. How can we have prioritization of the research that occurs, of the resources that are allocated, ultimately linked to what the beneficiary populations are calling for? And I think we still have a long way to go to get there, but we have some good examples of success that we can build on. Then there is a lot of work that is going on through the Global Health Network and in other areas for quality of research, quality of data, including around standards and interoperability, which is very important, and embedding data sharing all the way through the research cycle from the design through to sharing will have massive impacts if we can get there. How do we translate, and then how do we better? You will see all the way through my talk, there's collaboration and coordination everywhere, because from what I've seen with a big increase in resources in a lot of areas, what is really lagging behind, and again, the Global Health Network has a role, is how we do better in terms of collaboration and coordination. The clinical trials resolution is calling for us, while we have guidance that's available for individual trials or research, what we don't have is an overall normative guidance framework for how donors and member states can improve their research ecosystem. And we've been asked to develop this for clinical trials. Our focus in WHO is not at all restricted to clinical trials, but the scope of the resolution is clinical trials. So we will try to keep in mind as far as possible, making it more broadly applicable than RCTs. And we're going to be going through a big consultation process with all of the stakeholders about the pillars that we need to agree on for this normative guidance on ecosystem strengthening. And where we'd like to get to is a sort of an M&E framework so that member states and donors can self-assess how they're doing in terms of progress in strengthening their research ecosystem. And this is not for you to look at. I hope that the slides will be shared, but just to say that over the next year or so, what we're going to need to do is agree a matrix where certain elements of the ecosystem are needed at the national, regional, global level, and we need to have ways of tracking progress. How do we prioritize at the global versus the national level? How do we improve quality? How do we improve the networking? I think we've seen networks, really have a big role. And again, many of them in terms of their collaboration are hosted with the Global Health Network, but we need to identify where we have gaps in the networks and how we can do better to develop quality protocols that can be rapidly implemented. And I think a big part of this is having different sections for normal times and emergencies. And what I would really advise that you do if you work in endemic diseases is, rather than see that the resources tend to flow during emergencies and we're all starved of resources in normal times, make the case, which is true, that the resources that go in normal times for the core capacities that are needed for endemic infectious diseases, for non-communicable diseases, those are the capacities that member states, countries will have that can be deployed during emergencies. That's what we saw. It wasn't actually the emerging infectious diseases networks that were most useful. They had the disease expertise. What delivered most of the research was what had been set up beforehand for HIV, for example, in South Africa, for malaria in other countries, for tuberculosis, for influenza. So let's have this narrative that we drive the capacity strengthening for what are the priorities in normal times, and that they need to have ways of being rapidly adapted to emergencies. This is the research and development cycle. You will have seen versions of this. This is what we have at WHO. And what I wanted to show you is that we have a number of sets of normative guidances that span enumeration of clinical trials with ICTRP, large-scale R&D visualizations with the R&D Observatory, and then a number of other areas in research priority setting that are available. They're for all of our WHO staff, but they're also relevant for those of you working on, for example, research priority setting in other areas. We also have a bottom-up focused approach called EVIPNet, which is bringing evidence as far as possible into policymaking. I'm sure you would all know that, unfortunately, sometimes policymaking isn't actually based on evidence. And we all have a responsibility to, as far as possible, bring evidence into policymaking. When we know our minister is going to be issuing a policy on something, if we have a week or 6 months to really systematically try and present the evidence, that's what this model is about. It's active in 50 countries, and in the slides, there are links to many, many resources for those of you who have an opportunity to try and convince your minister to bring in the evidence that you've generated in your country. This is a model for doing that. We also have a visualization of all of the grants that are made in global health through something called the World Report. And what that shows is, unfortunately, where we have international collaborations, it is still absolutely the norm that the primary awardee is a high-income country institution. And we have these subcontractor relationships with low and middle-income country institutions. We want to get beyond that at WHO. We need to figure out how to move past that. And so the federated model that we heard about from the Global Health Network, we need everybody to move to that. And I personally think this is a big problem if we still allow this situation with subcontractors as the norm for low and middle income countries. This should not be okay. The most neglected of all areas is something that you all should be aware of, which is that the global burden of disease now is actually focused on non-communicable diseases in low and middle income countries. But if you look at the very small proportion of the grants that go to low income country awardees, they're not for NCDs. Therefore, the narrative is infectious diseases, maternal and child health. So the ultimately most neglected area is NCDs in low and middle income countries. And we need to figure out how to convince donors that this is a major, major need. Diabetes, hypertension, cancer in low income settings. You all know that we have big gaps in research infrastructure, in research total amount coming out of developing countries, and our R&D Observatory allows you to look at every single country and see progress. And you'll see that there are some countries that have made major progress, like Ghana and Kenya, but some that we really need to help to catch up. Then finally, with the last couple of minutes, I've got, this is now not WHO, this is me, so I take the blame for this. In my 25 years, a couple of things that I just wanted to highlight. Firstly, the more that we have communities of researchers that have shared objectives and their work is based on what their communities, their local needs are, what the beneficiaries are asking for in the first place, the more the research is going to lead to impacts on the ground. And so some of the practical research that I saw yesterday is absolutely aligned with that. But I still think a lot of the time we have to make the case and plea that we have the time and the resources to do this consultation, because we're not doing the right research if we don't do this. A lot of the projects that get funded don't necessarily have sustainable research capacity development at their core as the core objective. The core objective is some other output like product development. But I really would advocate that we very much put sustainability, equitable access, and capacity development at the front of everything we're doing, and convince donors to, to support this as much as possible beyond the pure capacity development projects. Because I think in my career, when I look back, it's whatever I have done to contribute to sustainable research capacity development that I'll be much more proud of than any individual project. More initiatives are not always better, and I see many, many new initiatives being launched all the time, generally by some northern donor that has an idea, a billionaire philanthropist. When we need the money, and I really congratulate any donors that have supported this conference in this kind of cross-cutting bottom-up approach. But we should sometimes push back on a new initiative if we can actually do better by supporting what's already happening and focus on more collaboration and coordination of what's already happening. I have seen in my career a big increase in the bureaucracy and the burden on researchers that are trying to get work done. There is, if we piled up all of the guidance documents that you're expected to follow, if you literally just printed out ICH, then it would just fill this entire stage. And there are many other guidances that we're expected to follow. The quality of your research is not equal to the number of pages in the guidance document that you're expected to follow. So somehow I think that we need to have an explicit objective of reducing the burden on researchers going forward while maintaining quality. And this is in the resolution, which I think is a big positive of the resolution. It talks about identifying the key scientific and ethical elements that will drive quality and outcomes. And we need to figure out how to do that while reducing the burden. And then just finishing, you will see in your career, and I'm sure many of you have already seen this, that sometimes the current system is not working and something is just wrong. And a good example would be HIV medication, access to HIV antiretroviral treatment. When I started my career, and I'll stop within 10 seconds, my first job as a medical doctor was here in South Africa in KwaZulu-Natal in 1996, not long after the end of apartheid. And at that time, the norm, what everybody said was, we're not going to be able to provide access to HIV treatment in South Africa. I'm sorry that your people are dying, but the way the current model works, it's not going to be possible. And people fought that. It was activists that fought that. And now the norm is industry supports generic manufacturing and we have access. But remember, that was absolutely not accepted. So we have to sometimes go through these incremental changes to have the battles to get to where we need to be. And sometimes the activists need to come in. And then finally, have the courage of your convictions. There are going to be many points where people are going to tell you that you can't do what you think is important, but if you kind of stick with it, then you'll get there. Thanks very much.
Thank you very much, Vasee. I really liked the challenge at the end. And I know you said those are your personal nuggets of knowledge. So we won't hold WHO to that. So I'll encourage, we have 5 minutes for questions from the audience. I have a few of my questions, but do want to allow the audience some time to ask questions. I believe there are microphones somewhere. So yes, please go ahead. Yes. So there's microphone in the back. Is it just one? Any questions, please raise your hands. Yes, there's some questions up here.
Thank you very much for that enlightening talk. My name is Lolem from Nigeria. I want to ask, when it comes to driving collaboration, when you have a lot of resistance with the institution where you work, what do you think works for someone who you are an early career researcher? What do you think you should do when you want to drive collaboration?
Yeah, I wasn't sure if it was collaboration at what level, across institutions, within your institution, across institutions. I think the important point that I have seen works is where you will find people who have shared objectives with you. And the more you can identify a community of researchers or people, it doesn't have to be pure researchers, health workers, nurses, and they have the shared objective. The shared objective could be something really practical and simple. In different parts, in different countries, people have stopped coming for antenatal clinic attendance. And we know this is a big problem. But as long as you can start with a shared objective, then whatever your differences might be with the framework that you're in, I think it's really possible to overcome that. So that would be my, my tip. Focus on the shared objectives and then figure out how you can work together. But that you will always, it will take a while, and sometimes it seems frustrating. It might take you, but that effort that you put in at the beginning of setting up a community with shared objectives will mean that the impact later on is going to be so much greater, in my experience.
So I think we'll take 2 questions back to back, if that's okay with you. Okay.
Thank you very much. My name is Eleanor Magongo. I'm a pediatrician from Uganda. I work with the Ministry of Health. I wanted to ask, what is the role for routinely collected data in using this to inform what we do in our different countries? Can routine data have a place or a role in the policy setting? Because a lot of data is collected almost weekly, monthly, quarterly. How can that play a role in what we are doing? And the other one is a comment. If we have a lot of funding, for instance, in the HIV programs, can we integrate what we are doing? Can we integrate NCDs, the same patients we see with HIV, have hypertension, diabetes? Is there a role for integrating and leveraging on the funds that are available in some of the programs? Thank you.
Okay, thank you so much. My name is Oyewole Edele from Nigeria. I just want to, it's a follow-up question for my brother here regarding data interoperability. Recently, we engaged on a project on COVID-19 where we have to operate a different reporting platform. So during these activities, we engage in some, just like you said, stumbling blocks. The organizations are not interested in sharing data. And despite the fact that we have common objectives, as you have advised, it's quite challenging for us. So I just want to know, what other strategy do you think we should adopt in order to, strengthen or foster collaboration? Thank you so much.
Sure. Okay. So I think we're going to have a whole session on data later. But I think these are really important questions, and thank you for the questions. My personal take is that in terms of sharing of the validity of routine public health data, it's vast. It's just absolutely vast. It's largely untapped. And I think a very important framing here is that a lot of the global initiatives that I hear about are requesting that you provide your data to them. And I think that really the important gap that I see is a major focus on supporting the capacity of routine national health information systems. And the countries that really have been able to go furthest with applying their routine public health data are those with sound national health information systems, like in the UK, where they have actually been able to do very, very large scale analyses for secondary purposes. So the key issue is, how do we have this narrative of supporting the national health information systems, rather than the narrative being, please give me your data so I can do an analysis in Europe or North America. Again, that's my personal opinion, but I really think it's very, very important that we figure out how to support the quality of national health information systems. And we'd absolutely need to have standards and curation efforts and interoperability. And from that, we can go. And I think another important point is that we shouldn't, the only way that we're going to get trust in, because there are a lot of concerns that I know that some ministries have about privacy, etc., electronic health records. The best way to ensure trust is to build trustworthiness in the way that we do this. So there are other models that are being used now, for example, with federated data analyses. There's something called trusted research environments. I think UK HDR are here. And they don't require you to export your data. They allow you to deploy code on the server without exporting the data and run analyses at very large scale. And I think when we don't necessarily have to always export our data, but we can run global analyses, that has a lot of additional possibilities. But in some cases, clearly we will need to aggregate the data, but then we have to focus on the quality and be very, very sure about the safeguards, because I have seen real examples where there have been leaks, and let's have trustworthiness. In terms of what you said, I think what you said about integrating between different areas, sorry, I'll stop, is actually probably the short-term way to go for NCDs, because what we see in developing countries is that there are HIV programs, TB programs, malaria programs, there's flu labs. They all have major comorbidity links with NCDs. And so if people are coming for HIV appointments, you can collect data related to hypertension, for example. And I think that probably is a really good short-term way to go to answer some of the NCD questions. Okay, thank you.
Thank you again, Vasee. We will move right into our 4 talks for the morning. So we'll have our presenters go one after the other. So hold your questions till the end. You can still include questions for Vasee as well. Our first presenter is Dr. Anani, and Dr. Anani is with program PACCI in Côte d'Ivoire, and he'll speak to us about building a research network through clinical research collaboration. Right after that, he'll be followed by Dr. José, who is with the Social Innovation in Health Initiative in the Philippines. And he will speak to us on the coordination of a global network for creating enabling environments for social innovations in health. Followed, right after that, will be Dr. Glenda, who is with Hospital Britanico in Argentina. And she'll talk about the presence of the scientific committee coordinator and how that contributes to enhance the academic development of the hospital. And then lastly, we'll hear from Dr. Fernando, who will then take us into beyond theory and looking at methodological mentoring to strengthen health research. So again, all of these topics relate to how we build and foster leadership and capable research teams. So I'll start with Dr. Anani, please.
Thank you very much. Good morning, everyone. Can you hear me? Okay, it's my pleasure and an honor to open this session of presentation by presenting the FISA study as a builder of a research network. I have 9 minutes to present what we did in 5 years. Let's go. Sub-Saharan Africa is prone to frequent epidemics, which needs a coordinated and appropriate response. One of the pillars of an appropriate response is a robust and effective research network. There are hardly any research network in Sub-Saharan Africa focused on epidemic response and research. the African Coalition for Epidemic Research Response and Training, ALERT, was put in place to help filling this gap. This slide shows the governance of the ALERT consortium. You have the executive committee that report to the General Assembly, and under this executive committee, you have all the work packages involved. We have 7 work packages coordinated by the work package 7. We have the work package 1 in charge of research, 2 lab, work package 3 IT, work package 4 operational readiness, work package 5 led by Trudy and Palmer, training, work package 6 community engagement. ALERT is 19 partners in 13 countries, 4 in Europe and 9 in Africa. As part of ALERT network, as part of this consortium, we implemented the FISA study. FISA stands for Fever in Sub-Saharan Africa, as simple. And the objectives of the FISA study was to describe the epidemiology, clinical aspect, and management of febrile illnesses in Sub-Saharan Africa. This is the scientific objective, and we have also the strategic one that was to build a clinical research network capable to respond rapidly to epidemics, and we will emphasize on this objective. How this study was organized, you remind this diagram is the same, but here we have the work package 1 that coordinate the FISA study. This work package 1 is led by Professor Pontiano here, and all the work packages are involved. You can see that here the work package 7 is not the coordinator, but was in charge of management of the fund. This other diagram shows the relationship, yes, between entities. We have the ICMC, the International Coordination and Monitoring Center, led by the work package 1 with 3 regional coordination with site, clinical site, and in clinical site, we had supervisor and PI. The supervisor was designated by the partners, the ALERT partners that proposed the site, and the PI was part of the local team. This organization contributed to build the network. The process of the setup was the following. We drafted a site selection procedure, and all partners that wish to propose a site did it. So we have 26 sites proposed by 16 partners. We validated the list by the steering committee, endorsed by the executive committee, and at the end, 15 sites enrolled participants in 11 countries. 6 countries in West Africa with 8 sites, 2 countries in Central Africa with 4 sites, and 3 countries in East Africa with 3 sites. I would like to greet Bernard, the coordinator of East Africa region. The key point of the implementation, drafting the protocol and development tool, approval of ethics committee, training. The first inclusion was in December 2019, and we ended the recruitment in December 2021. All these supported by meetings and monitoring visit, monthly steering committee meetings, monthly international coordination meeting, bi-monthly regional meetings. All these meetings and visits contributed also to build the network and strengthen it. We faced some challenges. Few challenges to summarize: the management of several ethics committees with different procedures. It was a challenge, and we faced a big challenge with one country, and we were obliged to work around with submission to a regional ethics committee valid because the National Ethics Committee was it was very difficult to move forward with this ethics committee. The COVID-19 pandemic that I call the great unexpected, with the reduction in inclusion and site visit impossible due to the restriction. This was also a challenge. Turnover in trained staff. We have several staff trained, but some of them left. And the communication difficulties due to language barrier because the network is a bilingual one, English and French. Fortunately, we have achievement. Introduction to research with development of interest in research in some teams, because we have several kinds of teams, beginners and also well experienced. But the beginners were very happy to be involved in this study. And today they are ready to welcome a new study. The management in a bilingual way. All emails, reports, documents were translated, and we manage things like this. Remote monitoring of the study to respond to an unexpected restriction. So due to restriction, we were obliged to make things remotely. Survey on laboratory capacity in collaboration with Work Package 2 and development of e-learning module on the protocol in collaboration with Work Package 5. This was some example of collaboration within the network. And establishment of a research network through linking of researchers from different fields, different languages, in different regions with different practices. This is very important. We managed to build this network with all these people. And today, beyond the work collaboration, some of them are very good friends. And within the network, we already developed other collaboration on new project, and we are still working on this. To conclude, I can say that FISA study succeeded in creating a network of research sites that have grown stronger over the years. Several lessons learned from the implementation of this study will be used to strengthen and expand this network. It is a model of research partnerships for an equitable response to health emergency. So this network is built and ready for new research on epidemic-prone disease. It's a message to all funders here, because the outlet will end next year. So we are ready and we are there. Okay, thank you. 5 seconds left. I did it. Thank you very much.
Good morning, everyone. I am Dr. René Bagani Cruz. I am part of the Social Innovation in Health Initiative Network Global Secretariat, and I will be presenting about our work in coordinating a global network for creating and enabling environments for social innovations in health. So our network, Social Innovation in Health Initiative, or as we like to call it, CHI, so the CHI, it was initiated and is still being supported by the TDR, and we receive funding from the Swedish International Development Cooperation Agency, or SIDA, along with our many partners. So to level off, we at the network define social innovation in health as a solution, which can be a process, product, practice, or market mechanism that is implemented through diverse organization models. The solutions have been developed by a range of actors or stakeholders, ideally including the communities where these innovations are implemented. And these solutions are in response to systemic health challenges within the context of the communities. It profoundly challenges the current system status quo, and has enabled healthcare to become more inclusive, effective, and affordable. So a brief overview of the network's history. So the CI network was established in 2014. It started with a innovation call, a global innovation call. The very first hub was established here in the University of Cape Town. Over the years, after the global call, we had country level calls for innovation, and then establishment of hubs. Currently, the network is still expanding. Currently, we have 13 hubs all over the world. So what is a CI hub? A hub is a research institution-based social innovation health hub. Usually these are university-based hubs that bring together various stakeholders such as the innovators, the community, academia, the government, private sector, and health implementers. The hubs do research on social innovations in health, also capacitize the various stakeholders for research. They advocate for social innovation in health, and convene the various stakeholders with the aim to institutionalize the innovations in their health systems. So overview of the network. I won't go through each organization, but just to show you the extent of the network. Currently, we have 13 hubs. I think it's a bit hard to read, but on your left, we have the very first hub here in University of Cape Town, CI South Africa, and we've eventually expanded to 6 hubs and then 13 hubs currently. We have hubs in Philippines, China, India, Indonesia, Uganda, Malawi, Rwanda, Ghana, Nigeria, Honduras, and Latin America and the Caribbean, and Sweden. So with this expanding network of hubs and partners, the network saw a need to have a coordinating body to coordinate the activities and the hubs. So in April 2020, which was just in time for COVID, the CI Secretariat was established within the CI Philippines. So part of the work of the Secretariat is to coordinate the hubs. We do this through monthly meetings, which provide the hubs platform to promote their activities, to share experiences, best practices, and their work, basically, to other hubs. We also meet with various partners of the network, and also with potential partners to explore potential collaborations and partnerships for social innovation in health. The CI Secretariat has also coordinated joint research grants, applications, and implementation. We have also assisted in publishing a special issue on social innovation in health in the BMJ Innovation Journal. Aside from that, the Secretariat also provides technical support in terms of communication to the hubs through promotional materials. We help the hubs to create promotional materials for their innovation calls, and also assist them with the branding of CI. We also manage the website, the email, online conference platforms such as Zoom for the meetings, and the social media accounts. We also help in sustainability of the hubs by seeking grant opportunities and funding for their activities. So just a brief overview of additional achievements of the hubs. We have fellowship programs, a crowdsourcing guide for research, and other various courses. So I would have loved to share with you pictures of face-to-face, but unfortunately, because of COVID, we had to be restricted in online settings. So on the top right, you would see one of our promotional materials. We try to make it as engaging and fun to capture our participants' interest. And at the bottom, you have example of our group pics in Zoom, where we try to make the most of it, given the technology. And although recently we've already started face-to-face meetings, as with the rest of the world. So on the top left, we have our lead, the lead of the Secretariat, Dr. Meredith Labarda, at TDR headquarters. So with that, thank you for listening. Yeah.
Hello, my name is Glenda Ernst, and in the first place, I would like to thank the host committee and especially Dr. Rumi for inviting me and give me the possibility to share with you what we do on the daily basis. I am molecular biology and work like basic research, and then I have clinical research, but currently I am a coordinator of scientific advisor committee, and it's, I am enjoy extremely much. Worked as train of resident to enhance the research capacities. Our work is entitled Presence of Scientific Advisory Committee and its contribution to enhance the academic development of the hospital. I work in the British hospital. Our hospital is a teaching hospital with more than 175 years in the training of health personnel through learning in healthcare practice and encouraging participation in research work. Why it's so important for us that health professionals learn to do research work? Because we are convinced that research could contribute to understanding how to improve the care we provide to patients. The Scientific Advisor Committee was created at 2016 with the aim of contributing to training of healthcare professionals in development of scientific research through implementation of continuous training strategies to improve the quality of care. We have a room and a coordinator that is in charge, who is in charge of meeting in person with research group and PhD students in order to provide methodological and statistical advice. And the rest of members are regularly weekly meetings to evaluate the new submitted protocols. There is a unified assessment guide to evaluation of each new project, and we evaluate different topics, and we put special attention in PACCI rule, especially with definition of the outcome, calculation of sample size, and rationale for their action. We invite our residents to think if thus the studies could be increased the knowledge or changes clinical behavior before to start. And give different feasibility for the researcher, like a step-by-step guide to writing a research project, step-by-step to opening user account in Buenos Aires, works a rate of computerized registration of all research projects called PRISA. And we follow the researchers during the complete performance of the project. We provide support since brainstorming, writing the protocols, we provide support with management of clinical sample, statistical analysis, and finally, we help to select the journal and publish their result. And have different annual training activities. The most important training activity is transversal course on research methodology. It is mandatory for the third year's resident and fellow. We each year have between 16 and 18 pupil, and it's important because some residents end with presentation of a research work. And each year we define different topic for interactive workshop. At 2022, we worked in systematic review and meta-analysis and statistics with art studio. And by the next year, we try to develop interactive workshop in randomized experimental studies and statistics with our medic, because we think that maybe is more easier for our residents. We encourage to increase the number of publications. When we was created, the resident presented our abstracts in different meetings, but never they publish their results. So we encourage them to share the information in different journals to build in breadth and share our information. And if good, our hospital is academic and always publish. Since we are created, the number of papers are growing. And on the other hand, is a priority for us to train leaders. So we want to work in develop durable lines of works. The number, since we are created, the number of PhD students and the numbers of the health department are growing. So I think that is important because the enthusiasm are growing noticeably. Since the committee was created, we had 400 protocols, more or less, with different lines of works. We have several lines in epidemiological studies, but on the other hand, we have several implementation studies with giving capacitation and measuring different outcome pre-post implementation. And we have an agreement with Catholic University and give me the possibility to develop different translational research, measuring different biomarkers or molecular markers. And we started to develop in different chronobiological lines of studies. Okay, in accordance with the Global Health Network, is our main objective to train personnel to improve each step for development research studies as daily tools. We encourage different residents that see that work each by day could be improved if we use the research works as a daily tools. And the key to leading research team is to be humble, a simple person, and with great generosity motivates the growth of other professionals, sharing all our knowledge and support. We try that the leaders must be an ambitious plan, but should be facilitate every step in the professional improvement for their peers. And to put in this, I am coordinator of the great scientific advisor committee, and they are the members. And we have different PhD students. They are my PhD student. I have 2 nurses, pharmacists, residents in traumatology. So I am so happy to see this growing.
Hello, everyone. Good morning. And first of all, to thank the Global Health Network for this great opportunity to be able to present part of our experience in the Institute of Clinical Effectiveness in Argentina, and be part of this newest member of the family of the Global Health Network Latin American Caribbean Network. I'm going to present just a pilot experience that we've started about mid-2018 and show you the first results and some ideas to reflect on that. So the mission of the Institute of Clinical Effectiveness is, as we all are seeking, is contribute to improve global health. And, and the main activities that we develop at IECS is education, research, and technical cooperation with other institutions or other groups. Argentina is the southernmost country in America, as you probably all know, and we're always facing a chronic, challenging economic situation, which never seems to improve. But despite all the efforts, actually research does not have a prominent role in training. And training is more geared to practice, to professional practice, and research abilities is usually not included in the programs. And we have almost no economic incentives or funding agencies to support locally our own research. So at IECS, the Department of Education set up this pilot project, which we call the Bridge Mentorship Project, which promoting and strengthening the training of health personnel, health professionals, to generate and lead local and regional research. And a great challenge, usually, for all educational and scientific communities. So this program, this pilot program, was set up in mid-2018, as I said, and we shared, because of the pandemic, we started doing our work at face-to-face consulting, and then moved to completely virtual by Zoom or any other platform, consulting with users. We were 3 mentors, 2 physicians and 1 nurse, solid training in practical experience, in research methods, in biostatistics, in research, good research practice, and research ethics. We set up a clinic, a methodology clinic, actually having appointments, offering about between 8 to 12 hours a week of 1-hour slots for for users who were willing to consult the team on any aspect or any phase of their own project, be it from the first or from the research question towards a manuscript preparation and help for publishing. It was partially funded by our own institution and the collaboration of the institutions of the users, but at no cost for the users themselves. So some of the results over those 3.5 years, we've had about over 1,500 consultations. And as you can see in the graph, it shows the pandemic entering in 2020. So we moved completely from face-to-face meetings to virtual meetings. Those 1,500 consults were actually done by 419 users, different users, and mainly there were half of them were physicians, 35% of them were nurses, and other health professionals were 15% of the users. The main reasons for consultation were preparing manuscripts, design of research protocols from the research question to designing the protocol, or conducting the study and statistical analysis of the results. Satisfaction of those completing the survey, 386, was very high. We were very happy with that, of course. And the mentees' achievements in this 3-year and a little bit over 3-year project were about several projects awarded, actually grant writing, whether local or international. Some papers, several papers published in peer-reviewed journals, many presentations in scientific meetings, over 60 presentations, scientific meetings, and we've had 8 master's and doctoral research theses. There's a great latent need for capacity building. We all know that. Methodological support goes beyond the theory. That's why the title of this presentation. Going beyond theory is really important. Training is important, essential, necessary, but not sufficient to really change the game. We need to go along after training, supporting the research, the development of the research projects, from the first idea to completing that, to manuscript preparation, to helping to publish, and then to go and advocacy. We move from practice, from research to practice, to use the best evidence. Then we move back to research to generate new knowledge. And then is after generating new knowledge, we need to go further from research to policy. And that's the way we are going to be able to change the story. The acknowledgement go to all the mentees first, the health institutions and medical societies that participated in this program, the Global Health Network, for allowing to dissemination of this pilot first project, and a toast for our joining the GHN Latin American and Caribbean Network. Thank you.
A big thank you to all of our presenters. I think the hardest task for any chair of a panel is trying to summarize what we've heard. I will not attempt to do that. I'll just highlight a few things as I encourage your questions. We have about 15 minutes for questions. So I thank the last speakers for saving us some time. But in general, we've heard from our speakers on just some really good lessons in creating partnerships to enhance the research we're doing. And then from our last speakers, I think those were very great examples on how we can actually build research capacity. And it includes a lot of hand-holding. I think sometimes we say, write a research grant. And for some people, they don't even know where to start. And then once you write the grant, how do you design? How do you think about it? Going through the ideation process, and then moving from now you have the grant, you've written, you have your outcomes, then what do you do? So I think those are really fantastic examples on how do we handhold, how do we mentor as we try our best to grow research capacity and grow leadership in research. So with that, that's my attempt at summarizing the last 30 to 40 minutes. And with that, please do raise your hand if you have any questions for our speakers. The microphones will come around. There's a question right here and 2 here. And I think let's start here and then go there, because this middle row had a lot of questions in the first session.
Yeah, thank you to all the presenters. I'm Sam Muhula from Kenya. My question is to Dr. Anani. You did mention that one of the challenges you experienced was getting ethical approval in one of the countries where you are implementing the study. And so you were to abandon the country-specific IRB and go to regional one. And in my experience, yes, it's a challenge to where you are doing a study in multiple countries. And so I wanted to know which is this regional IRB that you are talking of, and whether it is okay to bypass a national IRB and go with regional. How did you face further challenges collecting data in the country? Because those are some of the things that we've gone through. Yeah, thanks.
Yes, this ethics committee was also valid, right? Okay, it was also valid, like the National Ethics Committee. So we face big challenges with the National Ethics Committee. So on advice of someone in the country, we go towards the Regional Ethics Committee. Because if we waited again, this can lead to delay in the implementation of the study. So this was the big challenge, because most of the time when we have multi-site, multi-country studies, we want to start at the same time, but due to ethics committee challenges, sometimes we have some delay. So I don't know if I reply to your question.
Yeah,
I hope.
Thank you, Anani. So we'll take 2 more questions from this section, and then we move over to that section, please.
My name is Mahesh Maske. I come from Nepal and represent Nepal Public Health Foundation. Actually, my question is directed to Dr. Moorthy, because listening to all the speakers, then I thought I should direct my question to you, Dr. Moorthy, because everybody is emphasizing on equity issues. And you also said that while strengthening the capacity, research capacity, we should pay attention to sustainability and equitable access. So you have a long service in WHO. I'm quite interested to know what has been the top success stories of WHO in reducing equity gaps. Or, yeah, if you don't have many, you can share your frustration stories also. That's fine.
Well, that's a great question, and I don't have a perfect answer. I think all we can do is make the case to the funders that, and I think some of the funders, already do take this on board, but we should not hesitate, in my view, we need the funds. So don't get me wrong, nothing will happen without funds, but at the same time, we need to have hopefully a two-way dialogue with the funders about the importance of engagement with communities. And I think it should be possible to explain that the benefit and the outcome, the funders are looking for impact from their work. So if we can explain that we can improve the impact by really having a budget line and time to engage with the communities and really understand how the research is most likely to benefit the communities, then it will be in the funders' interest as well.
So we'll move to this side of the room, and no more hard questions for Vasee. Those are no longer allowed.
Thank you for this opportunity. I'm Farah Asif from Lahore, Pakistan. And my first question is for related to Alert Network. So you mentioned that in your region, many networks were not existing, they were lacking. And then you went on, you were determined, and then you developed this network and had your desired results as well. So what were the challenges you faced? Because how you made that change happen? Initially, the networks were not there, but you go on to take on this challenge, and then you develop this network. So because we believe that we can learn from this experience, because when you say this, that networks never existed, it sounds very familiar to me, to the context of Pakistan. So I would like to hear from you, because what were the challenges, and then how you just overcome those challenges? That would be great to know. And if I'm allowed, I have a second question. Can I ask now?
Let's take just one question so we can give others a chance.
Okay, that's great. Thank you. Thank you.
I think at the beginning of the consortium, we had people, we had work packages, but we did not know each other. So we needed to create the bridge, to create the links between people. And when we implemented the FISA study, we had several documents because it was very important for us to create communication. So several documents, several procedure that help us make people working together in the same way. I also talk about the meeting we had. We have a lot of meetings to discuss between researchers. And as I was saying yesterday, I used a lot WhatsApp. I have the WhatsApp number of all, at least one people in each country, in each work package. And I did not hesitate to send message to create this link. So as I said today, beyond the work, we are for some friends, and we work together for further challenges, further collaboration. So we try to create this network, but the FISA study was central. All the work packages worked around the FISA study. For example, the database was built by the work package 3. I take opportunity to greet Bai, the lead of this work package, the training work pack, all the work packages were involved in the study, you see, and we created this network through the FISA study, through the study. I hope I understood. Okay.
So apparently we do have to, that would be our last question, because we are the ones between you and the coffee break. And so we've been getting all these signs saying to stop. Could I ask Trudy just a last round from each of our presenters? Very short, thank you. So just to close our panel, and first of all, thank you very much. And I apologize that we didn't get to all of your questions, but maybe just a last lightning rod from our presenters as we close. Just one question, and I'll start with you, Fernando. And the question is the same for all of you. And it is, what is the most critical thing when we talk about building leadership and capacity in research? That's it. Very simple, just one thing.
Yes, very simple question, yeah. Actually, many things probably to work for leadership in research, but as I said before, training is important, not sufficient. Mentorship is important, and we need to go along after training and after formal training or informal training to develop research ideas. And we need to create networks. We need to collaborate. We need to reach out for help, give help, and reach out for help when we need it. And I think that the formula of creating networks and having developed different areas of research and strengthening those areas by the collaboration of many people around that network is a key.
Thank you. Glenda?
I am in agree with my colleagues, and I think that is very important to think that we need PhD leaders to motivate and grow and help the new research. When our residents start to work as researchers, they have very much enthusiasm, but sometimes we need to do more behind, because we need develop long and lasting leaders to train the resident, and we need to think that is possible, that the residents finish their resident studies and PhD in the same time, and they work much good with us to finish both of them together.
Thank you. Jose?
It's working. Okay. I think it's more of having an environment that would allow the prospective researchers to grow, having mentors to guide them, but having the room to allow them to make mistakes, because you can learn as much from a book, but there's really nothing to replace experience. So I think that's it.
What I can add to what is already said is that I think we have to involve people earlier when they are during their study. For example, for medical study, I think research should be teach very deeply at this time, not wait when they finished the study and they are on the field before try to catch up.
Yeah.
I think nurse, medical student should be trained very deeply when they during the study. I think this is something important, and we will see the fruit after.
Thank you.
For me, I won't add just to say something different to the others. I think instilling the culture of leadership in your training program is absolutely central. When I see the places that a lot of the leaders have actually come from, there are some places where there is this norm that we are going to create leaders. And I think that's really central. And then being part of a peer network of leaders. But also, the other thing that I think is really central is representation of these leaders, of you all, the ones that are the leaders. You need to be at the decision-making table of all of these initiatives, rather than just being people who are applying. We still are in a situation where the decision-making structures do not actually represent what we're trying to do. So until we move that, I think we're not going to get to where we need to be.
And with that, I thank all of you for all of your contributions. Thank you so much. I'll hand it back to Trudy. I think these were really fantastic conversations. We also have an opportunity to continue these conversations. Amref Health Africa is hosting a similar conference, and we'll be picking up on some of these themes. That conference will be in Kigali in March, and it's the Africa Health Agenda International Conference. So please do join us, and that way we can continue these conversations as we really talk about leadership and capacity building.